And knowing that the earlier you intervene, the more likely the patient is going to benefit, it like does definitely becomes like it becomes an issue as far as like making sure that uh, like that basically limits expansion of mechanical thrombectomy offering. Um, so we asked ourselves, when does a public health, like when does a treatment require a public health intervention? And are there certain criteria that need to be met? So we understood that you need a large health burden that's getting larger. You need a burden to be distributed unfairly. Certain segments of the population have unequal access. There has to be a highly effective and safe treatment for the condition. Um, the treatment has to be cost effective, and there must be evidence that upstream preventative strategies could substantially increase access to the effective treatment. And finally, there's a tangible cost to society. So in 2016, a metric driven umbrella campaign under the International Society of Vascular Interventional Neurology, Mission Thrombectomy was established with a sole goal of essentially accelerating access to mechanical thrombectomy for large vessel occlusion strokes, which is the most dangerous type of stroke. And the approach was to collaborate with worldwide stakeholders, providing peer mentorship, especially in like a low and middle income countries, with a leadership comprised of interventional neurologists, vascular neurologists, endovascular neurosurgeons, interventional neuroradiologists, neurointensivists, and emergency medicine physicians. We talked briefly about the core pillars, so we're not going to go over this again. Uh, we basically said this is, and this is basically in a nutshell, like our the model of like how like mission thrombectomy is organized. We have a core executive committee, which is essentially our board of directors, that reports to the like the Society of Vascular Interventional Neurology's board of directors. But at the same time, we have a global co-chairs. So in every region of the world, there is essentially a global co-chair because we would never essentially assume that we understand the politics and the challenges of every single area in the world. So we reached out and partnered with individuals and leaders globally. Each country has a country liaison, and each country, and in some cases, every country has multiple regional committees with a chair and co-chair. An interventional chair, an interventional chair where there are a neurologist, a neurosurgeon, or radiologist, as well as a vascular neurologist and an emergency medicine doctor. And of course, this work could not be done without our project management team, which we're very grateful for the work that they do for us. Mission thrombectomy has multiple subcommittees. I'm not going to go into all of this, but in order for us to standardize and like streamline the work, we found ourselves like forced to essentially do divide and conquer the work because there are only so many of us, and it's extremely important for us to have individuals subspecialized to essentially focus on these events. At this point, as I'm speaking to you, we're in more than 90 countries with over more than 100, 90 countries with more than 120 regional committees around the world. There are more than 600 SVIN thrombectomy committee members. And I will ask you if anyone's interested in the end. I have a QR code. Please feel free to reach out. And like we're always looking for new partners and collaborators. So one of the things that we said is we wanted to say we know that there's a problem, but without data, all we are is essentially a group of individuals with an opinion. So we don't want to have an opinion. We wanted to have tangible data. So we actually conducted a study called the MT Glass, the Mission Thrombectomy Global Access for Stroke. And this was a survey that was distributed amongst individuals around the world. 887 surveys, and we're very fortunate to have this published in the Circulation Journal. And 61 countries were included in our analysis. And I want to show you that what we found was global mechanical thrombectomy access is very low. Only 2.7 of all eligible patients actually receive mechanical thrombectomy. It is actually less than 1% for 18 countries. There is a 460-fold disparity between the highest and the lowest access countries. And 88% of lower access countries and low income countries compared to high income countries. There is definitely an income level, significance, and socioeconomic factors like healthcare infrastructure, cultural barriers, and availability, like all play a role in this. And you can see over here, um, assuming 20% of all strokes are large vessel occlusion strokes, countries like Bahrain, Singapore, the United States, those countries actually have like a decent number, like of mechanical thrombectomy, like of all perform mechanical thrombectomy of all eligible patients. But to put things in perspective, a country like Singapore offers it 40% of patients, but that is still 60% of patients do not receive treatment. That is actually the one of the best countries that we have. The United States has 37%, Japan is 32%, New Zealand is almost 32%. And those countries have the highest mechanical thrombectomy access score. Almost a third, uh, uh, like I said, almost a third have less than 1%. And there are seven countries, like of our countries, that essentially have zero access to mechanical thrombectomy. Um, so so then we said, okay, well, you can't really manage what you don't measure. And without data, like I said, we like you just have an opinion. We don't want didn't want to just have an opinion. We want to quantify the problem of stroke access disparity. Basically, in English, we said we needed like to know the real deal so we can come up with solutions that actually work. So we conducted a calculator to essentially be able to quantify the problem and identify, put our finger on where is the problem in each of these regions. So we conducted something called the mechanical thrombectomy access score. Um, this is a modified Delphi approach, like using experts in mechanical thrombectomy again around the world, global leaders, and ultimately it allowed us to quantify the barriers to global mechanical thrombectomy access. So if you get a chance, please feel free to essentially take that, like calculate it for your regions, and you'll be able to draw or create a radar map that will tell you where should you focus on first, essentially fix the core problem and essentially increase thrombectomy access. It's never usually just one thing. It's usually more than one thing. So when you're actually working, so as opposed to essentially working on pre-hospital care, you may say, you know what, I'm going to tackle the two biggest problems first, and this score will actually tell you what the problem is. Um, so over the past 10 years, from 2026 to today, we have almost, like I said, almost 100 regional committees. We have published more than 25 peer-reviewed articles. We've published a white paper on mechanical thrombectomy. We've launched a teleobservership and teleproctorship program. And we've established a day to commemorate mechanical thrombectomy, the World Thrombectomy Day on May 15th. We offer consultative services and certifying services for interventional labs called SILK. We have conducted multiple awareness campaigns. This is our white paper that's been translated at this point into more than 20 languages. This is a white paper essentially simplifying the science behind mechanical thrombectomy and stroke for policymakers um, in languages that they'll understand. When you get a chance, please log on to our website. You'll be able to access this. And the language that they understand is essentially it's all about like the economics of stroke. A coin I like to use is like strokeonomics. Uh, I hate to say it, but for around the world, and this is not unique to America, but death is cheap. Um, when a patient dies, that doesn't cost the society much, but it's when they survive with a major disability. That is essentially one person, potentially in the prime of their career. They could be the bread earner of that of that household. Now they can't work, and now somebody else has to stay home with them to essentially take care of them. So if you think about this, and now if the children were in school, now they have to essentially go to work. So it's a big problem. And we essentially attempted to quantify this. So when you download this, print it out, and you take it to your policymakers, um, like anywhere in the world, hopefully you'll be able to find your translated version of this. They will be able to understand this, and it is very simple, it is very clear, and it talks about why should they invest in this intervention. Yes, it may be a $10,000 like upfront cost, but you're ultimately saving like hundreds of thousands of dollars over the course of these patients who survive. Mission Thrombectomy is also awarded multiple awards for excellence for all of our regional committees. Um, we recently gave out all of our gold awards, our platinum, diamond award, and our platinum awards. One thing we also said was, as opposed to like this, mission thrombectomy started as a grassroots movement, but yeah, it started as a grassroots movement, but we basically said that instead of only doing a bottom up approach, we're going to actually do a top down approach in addition to a continuing the grassroots movement. So we established the Mission Thrombectomy Global Advocacy and Policy Subcommittee, uh, attempting to double down on a top-down approach to establishing two to essentially do it to working on this. Again, the MT Gap subcommittee focused on advocacy at the level of the United Nations and the World Health Organization. This way, when we actually go to the government of Nigeria, the government of Ghana, the government of Tanzania, we can say we are essentially working with the UN, like a United Nations or World Health Organization, and other global organizations to essentially help you and help our partners on the ground improve access to thrombectomy. Looking ahead, uh, we actually are planning on obtaining the World Health Organization consultative status. In 2025, we were fortunate to have been invited to represent Mission Thrombectomy and all of you and all of our partners at the New York, in New York City, at the UN General Assembly. And almost 3 years ago, we were able to secure the UN ECOSOC consultative status. Um, uh, Part of what we're trying to do is essentially categorize mechanical thrombectomy as an essential surgery. And the problem, believe it or not, part of the problem that we're facing is semantics. They say, "Well, is it surgery?" And I'm like, "Well, it's not really surgery. It's a procedure." They're like, "Is it a medicine?" I'm like, "No, it's not a medicine. It's an intervention." So we actually found ourselves that in order to speak the same language, we were like, "Okay, you know what? Let's just call it stroke surgery." This is surgery that you can actually offer a stroke to essentially reverse the damage or prevent further damage from the stroke. So we're essentially trying to have it designated as an essential surgery. However, we're very fortunate to essentially, and like I said, this ECOSOC consultative status gives us a seat at the table, allowing us to participate, comment, and present and consult within initiatives of the Commission of the ECOSOC at the United Nations. I was very fortunate a few years ago to meet with Dr. Tedros from the Director General of the World Health Organization during the Walk the Talk campaign in Geneva. And like I said, in 2025, we were invited to speak at the UN General Assembly as non-state actors and like I said, this designation has been instrumental in allowing us to push the field forward to some extent. We've also been represented at Davos because we do believe that stroke is an economical problem. And one of the things that we're very proud of is enlisting mechanical thrombectomy in the WHO list of priority devices in the management of cardiovascular diseases and diabetes. And quite honestly, that is part of the problem. Stroke is designated at the same level as cardiovascular diseases, so hypertension and diabetes, but we all know that it is much more acute, and the damage that it's going to cause is much more it is a hyperacute, non-communicable disease, and so because of this, we're very, very happy that at the very least, with a collaboration with many of our collaborators, at the World Stroke Organization, we were able to essentially ensure that it is listed at least in the list of priority devices for the WHO. So I want to shift gears a little bit just to talk about training. So, like I said, and this is no news to this audience, that mechanical thrombectomy is a proven life-saving intervention. And we already talked about how access is inequitable. This gap is especially obvious in low and middle income countries, with a major bottleneck being the shortage of neurointerventional physicians and limited technology. So we've been conducting, over the past 10 years, we've conducted more than 50 workshops. And like everything that we do, we always, at least when I when I start when I got involved with mission thrombectomy and I've taken over as the global chair of mission thrombectomy, I wanted to make sure that everything that we're actually doing, in collaboration, of course, with my partners at on the board on the core executive committee and Dr. Yavagal and Dr. Kaz Asif, we wanted to make sure that these workshops are actually doing what they're intended to do. And is there any data that actually says that these workshops actually benefit patients or benefit our physicians? And does that necessarily translate into effective, improved access for patients? So we looked at the training outcomes across procedural skills, operator confidence, and patient impact. Um, and we actually published a paper called Innovation in Thrombectomy Training, a systematic review and expert recommendations from SVIN Mission Thrombectomy initiative. We sought to evaluate the effectiveness of simulation-based MT training in improving procedural skills, confidence, and clinical outcomes amongst neurointerventional teams. We synthesized current evidence to identify the best practices and support the case for expanded implementation, simulation-based training in stroke systems of care. So this meta-analysis of 8 studies were included with 3 studies eligible for the meta-analysis. What we actually found was that these training courses allowed for an average decrease of almost 18 minutes. The number of handling errors were reduced by 6-fold. The contrast volume was lower, the fluoroscopy time was lower, and there was an average increase in procedural steps completed was almost 6.5 steps. This structured simulation-based mechanical thrombectomy training, we believe that, at least now we believe that it can significantly enhance procedural skills, clinical decision-making, and professional confidence amongst neurointerventional teams. Now, I'm not saying that we can take a primary care doctor, no disrespect, but take somebody who has no background in this, train them to do mechanical thrombectomy on a flow model, and expect them to go back home and do thrombectomy. It is not that simple. This is something that complements some basic training, some existing basic training. We are this is now part of the overall mechanical mission thrombectomy offerings that we're able to provide. Like I said, this is a global movement. Since stepping into the role of global chair, I've had the honor, alongside my amazing colleagues on the core executive committee, our amazing group of mission thrombectomy ambassadors. We've given dozens of talks, literally all over the world, and to audiences across dozens of countries, because this has never been a one-person mission. It's powered by expertise, passion, and the reach of our team. This is us all. This is us in Turkey. This is happening in Iraq. This is another one in Turkey. This is in Mexico. This is another one in Mexico. And over time, we basically decided that we're going to essentially present and establish called the Mission Thrombectomy Teleobservership. And the teleobservership allows people around the world to watch cases live as they're being done. So stories like that don't happen without investing into people. Our program was launched in July 1st with the first class of 37 observers. The first batch basically concluded in January. We're in the process of enrolling the second class. Many of the 37 first year, the first batch, opted to continue into into a second year. Additionally, we have the Mission Thrombectomy Connolly Neuroendovascular Fellowship that was launched in 2023. Now in its second year is training a new generation of global experts. And we're building capacity, not just awareness. I don't know about you, but we love WhatsApp. And that's how we communicated and allowed our fellows to know that there is a stroke alert, or there's an AVM that's being embolized, or a ruptured aneurysm, or a subdural with a midmeningeal artery embolization, because it's not only thrombectomy that they need to learn, it's access. And you can actually learn all of this through these videos. During these cases, they're able to communicate with the interventionalist while seeing what their hands are doing, and they're speaking with them live. We're in the process of launching, again, this teleproctorship, utilizing our network of experts. So you can see over here, this is Dr. Brajesh Mehta doing a thrombectomy before and after.
So for this,
and you can actually hear him
front
here
row,
speaking about like how he's embolizing an AVM.
we've now advanced the Scepter Mini balloon microcatheter up to the junction of the nidus and inflated the balloon.
So this is a recording, a live recording of something that is happening real time, and you're going to be able to
sufficiently penetrating the nidus. Periodically, we'll do intermittent angiography to assess for progressive closure.
At the end of every case, there's a debrief session to ensure everything was completely comprehended. At the beginning of the and the end of every one of these courses, there's a pre teleobservership survey and a post teleobservership survey to see how they're overall, how do they feel that they have improved. This is until November. We've done almost 111 cases that at this point are in our library online. You're all welcome. Whoever is interested to sign up, you're able to access this library of live cases. And they're they're being categorized into, for example, tandem thrombectomies, tandem strokes. How are these essentially? What was the technique to essentially tackle them? So if you have time, you're welcome to essentially scroll through this and get access to this. SILC is a stroke interventional lab certification. It's our initiative to standardize neuroendovascular lab training and quality around the world, because stroke care should not depend on geography. It represents a comprehensive framework designed to guide the development and standardization of stroke interventional labs worldwide, with a focus not only on large vessel occlusion, but a primary focus on large vessel occlusion, but at the same time, all aspects of neurointerventional care. It enhances patient safety, improves clinical outcomes, and increases the efficiency of stroke interventional procedures. So far, 7 sites have been initiated in three in the United States, 1 in South America, 2 in South America, and almost 3 more in Asia. And with that, I'm going to end a little bit early so we can spend at least 10-15 minutes to discuss this. I'm going to leave this page open so you can scan these codes and learn more about mechanical mission thrombectomy if you want to sign up for the teleobservership. And if your site wants to become SILC accredited, please scan this. It is free. Like everything we do is free for our partners on the ground. We're powered by generous support from industry. But if anyone's interested in this, please let us know. These is some of our offerings. There's a lot more that we do. Yeah, and with that, I will hand this over to the moderators, and happy to take any questions.
Thank you very much, Dr. Al-Mufti, for such a fantastic presentation. Looking through the chat, I think I see. I don't know if anybody has a comment to make here now before. I don't see any question in the chat. Is Professor Bankole back, or he's still having technical issues, or probably in the OR?
Yes, I'm back, but thank you.
Okay. Yeah, so Dr. Bankole wasn't here at the beginning, but just a reminder that these grand rounds, it's hard work, of Dr. Bankole, Professor Bankole, sorry. And we are really excited about the future as we work together with all those other stakeholders to facilitate world-class comprehensive neurointerventional services and stroke care in Nigeria, as well as in other West African countries. More information will be forthcoming in future sessions about opportunities for anyone interested in engaging in this much needed work. Does anybody have any question to ask. This is the time for questions. Otherwise, I will hand over to Professor Bankole to close us out for the day.
I think there's a question on the chat now.
Okay, so what are the basic equipment to set up thrombectomy care and the estimated cost? This question is from Gian. I think the question is for Dr. Mufti. I doubt if you would have a cost. I'm happy to hear that.
Yeah, no, I think that's an interesting question. Obviously, the cost is going to be very different, like in different places and different areas in the world. The cost up front essentially have usually we say as a start, a single plane should be more than enough. You don't need a biplane. It doesn't have to be state-of-the-art single plane, like a single plane doesn't even have to be a new single plane. Like I'll give the example of like a colleague of mine who Dr. Haytham Dubabna, who essentially did it on a C-arm, is able to do thrombectomies on a C-arm because out of desperation, he's like, I don't have anything else to do this with in some hospitals, and that's what they're able to do. I don't know if I can give you a specific number because the number is going to vary significantly between different regions and what's already available. From a tool perspective, from a thrombectomy devices perspective, again, it's going to be very different from one country to the other. Part of the work that we can actually do as part of our consultative services, and this is available to you for free, is essentially work with you to essentially figure out like how much is this really going to cost. So when you go to the government and you have a very clear plan, this is how much a single plane is going to cost us. This is the basic number of aspiration catheters, wires, rotating hemostatic valves, three ways, heparin bags that we're going to need. So and the cost is going to be different whether you're establishing this in Africa versus Asia versus South America versus even Eastern Europe. I think it's a great question. The answer is it's not as simple as it's not a very clear number, and the number is going to differ based on geography.
Yeah, and someone else is asking about services where it can be accessed in Nigeria. Right now, in Nigeria, we do not have a designated area or any place where you can go for mechanical thrombectomy. However, few individuals have engaged in thrombectomy, especially through this WASI project. And Dr. Okafo is here. Someone is asking about where you can access thrombectomy in Nigeria at this point. I don't know if you want to say one or two words about that. Dr. Okafo.
Good morning and afternoon to everyone. Dr. Al-Mufti, thank you so much for a wonderful, as usual, world-class presentation. We're very grateful to have you take this grand round. In terms of the access to mechanical thrombectomy, I'll be brief. I have a personal story similar to that of Dr. Al-Mufti. It was a colleague of mine, a classmate from medical school, whose sister suffered a stroke, and he happened to be in the eastern part of the country. And then we ended up, Dr. Chizoba knows about this because we were both involved. And they drove all night, almost, I don't know how many hours, 8 to 12 hours across to get to Lagos. And one of the providers, who's a body IR trained, but he was able to do the mechanical thrombectomy, Dr. Nilowo, and got that procedure done. And she made quite a very remarkable, wonderful recovery. We would love to see this expand. And that's the whole idea of having this meeting, to be able to train the locals, the neurosurgeons, neurologists, and radiologists locally, Nigeria and Ghana, all of West Africa. We have 16 countries in West Africa. We have a very long way to go, but we're starting from somewhere.
Yes. I will skip some of the questions on the chat because they're straightforward. Someone is asking about being interested in teleobservership. There is a QR code on the screen that was displayed. You just have to copy that and go to the website and register and take it from there. Regarding what are needed, someone's asking about benefit. Within how many hours of stroke is mechanical thrombectomy beneficial? Well, within 24 hours of onset, up to 24 hours of onset. That doesn't mean that we have to wait for 24 hours before we attack the vessel of interest. Ideally, if you have a CT scan that is also able to do a CT angiogram, you should be able to locate the position of the clot. From the patient's symptom, you could tell which hemisphere or what part of the brain is affected by the symptoms you're looking at, and know what target organ to go for, target vessel to go for. I know that perfusion scans are done as well in advanced countries, but using an aspect scores just with the CT can also guide you in places where you do not have CT perfusion. The basic thing is, I think that first level has been scaled by Nigeria. Most places in Nigeria can do a CT scan and a CT angiogram. The training is what is required for you to be able to do. A question I do have for you, Dr. Mufti, Dr. Mufti, is so teleobservership. We trained in neurointervention. It's different from observership when it comes to hands-on. Do you guys is there a way where the trainees get hands-on after the observership period before they can actually go into the field?
Yeah, no, that's a fantastic question. So the teleobservership is just one aspect. It's a way to essentially allow people who are, for example, I can give you like an example of at least 10 interventionalists I know around the world who are more comfortable doing aneurysm and AVMs, but not comfortable doing thrombectomy because they haven't really had the exposure to it. So this allows them to hone their skills. It is a higher level course. It is very technically challenging. It requires some basic knowledge. But you're right. How does this translate into improving your hands-on skills? Like a hands-on fellowship in America, for example, is very hard. I'm sure, but you and Dr. Okafa can attest to that. It requires you to take some licensing exams before you're able to do this. So what we're actually launched through the through the Connolly Mission Thrombectomy Fellowship is essentially identified sites around the world, in South America, in Africa, in Europe, and in Asia, where select individuals who can basically go train for 1 to 2 years. This is funded by Mission Thrombectomy. So we know that like those sites are going to offer solid hands-on training. We will fund their stay in those countries, and they'll essentially be able to obtain this hands-on training as opposed to going through years of training in America to get this, like the hands-on training, and it just becomes, it's just much more complicated. Additionally, one thing that we're actively working on, and if anyone's interested in this, they can demonstrate some basic, like existing basic skills. We're working on some live animal courses where you're actively able to do a thrombectomy on a live animal, perhaps a pig, to get a sense of exactly how is it that you're going to retrieve the thrombectomy, retrieve the devices. We're doing this as part of, in collaboration with one of my good partners and a member of our core executive committee, Dr. Tara Kashout in Chicago, University of Chicago. The course is in July, if I recall correctly. Again, we don't take this easily. We don't take this for granted. It is not easy to get to America to do this, but it's definitely something that we fund for individuals who we believe will benefit from something like this. In the sense that they have some basic like hands-on training, that something like this is going to take them to the next level.
So for those individuals, say, what do you look out for as the minimum qualification? I know, of course, you mentioned people in primary care or internal medicine physicians would not ordinarily, be those kind of people you're looking at. What do you document or recommend for minimum qualification before people can embark in the hands-on?
I mean, I would say some exposure to be access to the angio suite, ability to sort of perform basic to have some basic angiographic skills. If you're able to do like more advanced interventional skills, that the more the better. I think that helps us significantly. For the most part, like I said, it's not straightforward. It's on a case by case basis. It's nothing against internal medicine doctors. Again, personally, I believe the field needs people who can do this globally, and I believe it should be specialty agnostic. If it's a country that only has doesn't have a lot of radiologists, but has a lot of cardiologists who are able to do this, and are already they have access to a biplane, single plane. They already have access to some of the devices. They know how to navigate a wire and a microcatheter and an aspiration catheter and a centrifuge. By all means, let's do that. Until we are able to train individuals who can understand the brain, let the cardiologists do this first. There are places, and we work with, in some countries, it's emergency medicine, believe it or not. The vast majority of cases, it's radiologists, neurosurgeons, and neurologists. But we don't have a problem with anyone who has the preliminary basic prerequisites of essentially understanding the disease process, having some basic angiographic skills that we can help them take to the next level.
All right.
The last question here is asking about the outcome of thrombectomy comparable. How is the outcome of thrombectomy comparable with the use of thrombolysis alone?
So what we know is, I think the one thing that we learned from the 2015 randomized controlled trials in large vessel occlusion strokes, mechanical thrombectomy is undoubtedly superior in terms of the ability to recanalize a blood vessel with the functional outcome. So at this point, there's no comparison. I would still say if you're able to give mechanical fibrinolytics, give the fibrinolytics. That does not preclude you from undergoing mechanical thrombectomy. The mechanical thrombectomy benefit is overwhelmingly beneficial.
Yes, in addition to what Dr. Mufti said, giving thrombolytics does not preclude doing thrombectomy. We've had few cases where someone received a TPA or TNK, as most centers do now in the US, and they get to the lab, and you access and the vessel is recanalized. But it's only I've only seen that maybe once or twice in my entire 7 years of doing this. Any other question? Before I hand over to Professor Bankole.
So once again, Dr. Mufti, we want to thank you very much for this wonderful presentation. We just want to mention to the audience very quickly that we do meet on a weekly basis on Saturday for an hour. So as part of, to augment what SVIN is doing and our collaboration as the West African Stroke Initiative with them, we do have a weekly session. So if you want to learn more about endovascular treatments, thrombectomy, learn about the angiography, the anatomy, please join us on Saturdays. And Dr. George, please post your contact on the text box so everybody can see it as well. Thank you very much.
All right. Thank you very much, Dr. Al-Mufti. It was a very interesting presentation, and your passion definitely shone through the presentation. Thank you to all that have joined. I think that the difference in time made a few people miss out on the presentation, but the recording is available on the WASI YouTube page. So please feel free to go to the WASI YouTube page and listen to the recording. Our next grand round will take place on Wednesday, April the 8th. Please keep an eye out for the flyer, which we'll post later. We look forward to seeing us all there. I think the groundswell of support is increasing, and we need to just keep the momentum. And I'm really happy with the work that SVIN and Mission Thrombectomy is doing. So today's recording, as well as previous meetings, are available on our website, the www.wasi at Wasi Official 1. The link for the channel will be in the chat as well. So thank you very much. I believe that the session has been very educative and the time has been well spent. So have a wonderful rest of the day.
All right. Thank you so much for having me. Just want to take a final moment to thank you all for the kind invitation. Also thank our collaborators and our leaders from Mission Thrombectomy in Africa. I would say no doubt Dr. Okafu is and Dr. Ezepwe are leaders, and yourself, of course. You're all leaders in Africa. I'd like to take a moment to thank Dr. Mihari, Dr. Carol Budowski, and Dr. Fahim from who are working with Mission Thrombectomy on Africa in general, but also in Tanzania. We're trying to extrapolate the experience of like our work in Tanzania to Nigeria and ultimately, hopefully, Ghana. All right. Well, again, thank you so much for the invitation. Honored to be here, and please let's stay in touch. Yeah, best of luck.
All right. Thank you very much. We'll do that. We'll definitely stay in touch. Bye.
All right. Bye-bye.
All right. Thank you. Bye.
Bye, everyone. Thank you. So Fawaz, thank you so much.